Module 3, Oral Effects of Common Medications Prescribed for Long-Term Care Residents. This module will discuss the common oral side effects of medications taken by residents in long-term care facilities. More than 90% of the elderly take prescription medications each week. 57% take 5 or more medications daily. 12 to 20% take more than 10 medications daily. The term used to describe the use of multiple medications by the elderly, generally those aged 65 years and over, is called polypharmacy. Polypharmacy is very common for nursing home residents. The metabolism has also changed in the geriatric population. As we age, the metabolism of chemicals is not as efficient as it used to be. Drugs stay in the system for a longer period of time. So the resultant polypharmacological interactions have an increase in the number of medications prescribed. We have a decrease in the metabolism rate of drugs, and thus more reactions that can cause issues in the geriatric health. Common conditions of the elderly requiring medications include hypertension, stroke and blood clots, diabetes, chronic pain, constipation, arthritis, depression and psychological disorders such as dementia and obsessive-compulsive disorders, Parkinson's disease, and seizures, just to list a few. Some diseases or conditions, such as arthritis, not only need medication to reduce inflammation and combat the autoimmune disease, it also has a secondary problem affecting the oral cavity due to difficulty with dexterity and manipulation of the toothbrush. Other conditions, such as obesity, can lead to several medical consequences, resulting in diabetes, hypertension, depression, and chronic pain. Each of these conditions requires specific medications to regulate or manage symptoms. Common oral side effects of medications that we will focus on are xerostomia or chronic dry mouth, taste alteration, candidiasis, gingival hyperplasia, stomatitis and mucositis, lichenoid drug reaction, dental erosion due to gastric reflux, and dental caries. By far, the most common side effect of medications is xerostomia. That is a sensation of dry mouth due to decreased salivary flow. Saliva rinses the mouth, helping to clean the teeth between meals, and buffers the acid produced by food and bacteria, allowing the teeth to remineralize. This photo shows the ventral or underneath surface of the tongue. Normally, this area is very moist, and where several salivary glands excrete saliva. Notice how red and dry and parched this oral mucosa is. Currently, over 400 drugs are identified that can cause dry mouth. This includes about 13 different categories of drugs. Some of the medication classes causing dry mouth include antihypertensives, which treat high blood pressure, diuretics for water retention, antibiotics, antihistamines for allergies, antidepressants, antipsychotics, anti-anxiety, anticholinergics, anticonvulsants, narcotics, medications to treat Alzheimer's disease, medications to treat Parkinson's disease, medications for arthritis, and laxatives, to name a few. What are some of the symptoms of xerostomia? Because there's such reduced saliva flow, it mainly affects the oral mucosa. There is difficulty in swallowing and speaking. The resident might have an altered taste perception. They could have oral discomfort or a burning sensation, especially of the tongue. They might have poor denture retention because there's not enough saliva to create a sucking mechanism to keep the dentures in place, or the resident might be so sore that they're not able to wear their dentures at all. Xerostomia can also contribute to fungal infections. Here you see evidence of angular cheilitis or sores in the corners of the mouth. In some cases, you may see an influx of yeast organisms, which are natural flora, but are opportunists when the pH of the oral cavity changes. This not only can trigger infection, but without the natural flushing of bacteria from the body provided by saliva, oral malodor or bad breath can also occur. Due to a reduction in saliva flow, there is a diminished capacity of the body's natural flushing action, and also a reduction in enzymes that break down food and plaque. The longer dry mouth symptoms persist, the more likely residents will develop dental caries, especially along the gum line, such as what you see here. Secondary to this is inflammation, which is the cause of gingivitis and periodontal disease. Managing xerostomia can be tricky. Inciting medications that will exacerbate dry mouth symptoms should be avoided. Irritants, such as alcohol consumption, too much caffeine, or even tobacco, can contribute to xerostomia symptoms. Also, sugar-containing drinks and candies should be avoided if possible. Residents should be encouraged to sip water frequently, especially when they're eating. There is no one-size-fits-all product for relief of dry mouth. Help the resident try different products until one is found that best alleviates their dry mouth symptoms. Some health products include special toothpaste and non-carcinogenic xylitol products, which can help alleviate dry mouth symptoms. Xylitol will be found in some gums, mints, or candies, or there are some newer products coming out on the market as we speak. Also, relief may be found in oral lubricants that are sprayed or placed on the tongue and spread around the mouth. Good oral hygiene is absolutely essential no matter what product you use, so helping the resident at least brush their teeth 2 times a day will help immensely. People that have xerostomia have an increased risk of dental decay. Because there is reduced saliva flow, there is a less capability to buffer the acids produced in the mouth. With an acidic pH balance, tooth structure is demineralized, and that leads to rampant decay. So, products that should be considered for the resident with xerostomia would include topical fluorides, fluoride varnish, or prescription fluoride toothpaste. Another strategy for xerostomic patients would be to consider an alcohol-free chlorhexidine rinse 2 times daily to reduce the bacterial count in the mouth. Biotene products are over-the-counter and easily available in grocery stores or drugstores. Biotene products include a toothpaste, a gel, and a mouth rinse. The Biotene toothpaste has no sodium lauryl sulfate. That is the foaming detersive action in regular toothpaste. So the Biotene products are designed specifically for dry mouth. If you have a resident that has a severe case of xerostomia, perhaps pilocarpine could be prescribed for them for systemic use. Dysgeusia, or more commonly known as taste alteration, is another side effect associated with over 200 drugs. This condition is often overlooked by caregivers and clinicians and can have a major impact on a person's quality of life. It often leads to depression and weight loss. Their sensation of taste may be decreased, altered, or made unpleasant. Some people try to compensate by eating sugared foods, which can lead to dental caries. Some medication classes causing dysgeusia include antibiotics, antifungals, antivirals, cardiac medications, chemotherapy agents, Parkinsonian agents, migraine agents, thyroid medications, psychotropics, and localized radiation therapy that is administered to the head and neck area. While previously discussing the symptoms of xerostomia, it was mentioned that due to a reduction in salivary flow and changes in the protective qualities of saliva, it can increase the possibility of bacterial, fungal, and viral infections in the mouth. Here you see an opportunistic fungal infection in the mouth caused by an overabundance of Candida and predisposing factors. Notice how red the uvula is after wiping off the fungus. This is a distinguishing characteristic of a fungal infection or candidiasis. It can be wiped off, leaving an inflamed area underneath. Lesions can appear in several different forms and can also be present as a mixed lesion, such as angular cheilitis. Some medication causes of intraoral fungal infections include antibiotics, especially broad-spectrum antibiotics, chemotherapy treatment for cancer or antineoplastics, immunosuppressant drugs, and steroids, including inhalers. Management of an intraoral fungal infection may involve consultation with the resident's dentist or physician. Some topical products that may be prescribed are nystatin creams for denture wearers, applying it 5 times a day, or for residents with teeth, clotrimazole troches 5 times a day. It is important not to mix these 2 drugs as they will interact. If a resident has chronic candidiasis, especially of the larynx or the esophagus, a consult with the physician for possible IV medication must be made. If a resident who wears dentures develops a fungal infection, the denture must also be disinfected. The most inexpensive way to disinfect a denture is by using a dilute solution of common household bleach. Soaking the denture in 1 part bleach to 10 parts water for 20 to 30 minutes or overnight will kill microorganisms and remove any discolorations and stains. Make sure to thoroughly rinse the denture with water. You may want to consider mixing up a solution to use nightly. For nightly storage, mix 1 part bleach to 100 parts water, or roughly 2 tablespoons of bleach per gallon of water. Store this solution in a gallon container and use it to soak the dentures overnight. Again, remember to rinse thoroughly with water when delivering the dentures to the patient. Gingival enlargement or gingival hyperplasia is a common oral side effect of several medications. Gingival enlargement is an overgrowth of the gingival or gum tissues and appear to balloon around the teeth. The gingival or gum tissues may appear swollen around the teeth and could be painful to the resident. The tissues could appear fibrotic or red and inflamed. Some medications that cause gingival enlargement include cyclosporines, calcium channel blockers, and anticonvulsants. The occurrence of gingival enlargement is usually medication dose related. Good daily toothbrushing and other oral hygiene regimens is imperative to curb the side effect of gingival enlargement. If gingival enlargement is severe and affects normal day-to-day chewing and mastication, surgery to remove the excessive tissue may be necessary. Another medication side effect commonly seen in long-term care residents is stomatitis and mucositis, which is an inflammation of the mucosa, which is the lining tissues of the cheeks, gums, tongue, lips, throat, palate, and floor of the mouth. Symptoms could present as erythema of the palate with a cobblestoning appearance of the mucosa, commonly called denture stomatitis. They could also have erythema and multiple mucosal ulcers, especially if they are receiving radiation or chemotherapy. Two major medication causes of intraoral stomatitis and mucositis are chemotherapy drugs and radiation therapy if it is given locally to the head and neck region only. Management of stomatitis and mucositis will usually need a physician or dentist consult to prescribe medication for palliative use. Topical antifungals such as nystatin creams might be utilized for 2 weeks. Alcohol-free chlorhexidine or salt soda rinses are also something to consider. Other palliative treatments for pain, such as magic mouthwash, which is basically Benadryl with Maalox, may be prescribed. And there is a new prescription rinse for oral mucositis called Episil, which is a lipid-based medication in a multi-dose container. Medication causes for intraoral lichenoid drug reactions include antihypertensives, IV bisphosphonates, NSAIDs, broad-spectrum antibiotics, antidepressants, chemotherapy agents such as antineoplastics, and antiepileptics. Lichenoid drug reactions are white, non-wipeable plaques with ulcerations, such as what you see here on the side of the tongue and inside the cheek. These are also frequently associated with pain. The non-wipeable aspect of these lesions is a distinguishing characteristic from candidiasis or a fungal infection. Here are 2 more photos showing lichenoid drug reactions of the oral mucosa. Here on the left is a photo of the left buccal mucosa, or the inside of the left cheek. And here on the right is down in the lower right mandibular vestibule. Management of lichenoid drug reactions is primarily palliative. Generally, topical steroid creams or systemic steroids are used for a short period of time to alleviate the symptoms. Dental erosion is a loss of tooth structure through a non-bacterial chemical process. One cause of dental erosion commonly seen in the elderly is gastric reflux. Dental erosion is a loss of tooth structure, especially along the gum line, but could be all over. A person with dental erosion could experience generalized hypersensitivity of their teeth, making them sensitive to hot and cold foods or drinks, which makes it difficult for the resident to eat. Medication causes of gastric reflux include beta blockers, calcium channel blockers, progesterone, and nitrates. How do you treat dental erosion due to gastric reflux? First and foremost is management and treatment of gastric reflux disease to reduce the exposure of acid on the teeth. Sensitivity toothpaste should be used exclusively by the resident. Fluorides, including fluoride varnish, trays, or prescription toothpaste or rinse, should be utilized daily by the resident. Calcium phosphate products such as MI paste might also be used. A xylitol regimen, including gums, lozenges, and rinses, should also be included. Dental caries is a very prevalent oral disease affecting more than 50% of the elderly with teeth. Root surface caries is the most common location. Dental caries is a progressive disease, usually asymptomatic in the early stages. The resident could experience tooth pain during eating, with temperature changes, or spontaneously. If left untreated, dental caries can lead to an abscess or even cellulitis. Medication causes contributing to dental caries include sugar-containing medication preparations, such as your syrups, and especially cough drops. Delivering crushed medications given in applesauce, juices, or puddings. Preventive management of dental caries could include changing or modifying the medication delivery method, such as using sugar-free products to deliver the crush medications, daily toothbrushing, preferably 2 times a day by direct care staff, using xylitol gums, mints, and their other products, a fluoride regimen, such as mentioned earlier, and restoration of the teeth by a dentist. The take-home message of this module is to remember that medications may have negative oral consequences, which should be monitored and minimized whenever possible. And bottom line, good oral preventive care is paramount to reducing the symptoms of medication side effects to maintain quality of life.